And I worked for 3 different health plans for about 10 years, and my job was going out to physician groups and saying, look, here's your problem, here's your bed days per 1,000, here's your readmission rates, you ought to change, here's all these programs we offer, please do it. And they just smiled politely and sort of waved me out the door because there was a line of other health plan executives right after me sort of coming with similar messages. And the physicians were not listening to the insurers because it was like pushing a string. So now being on the inside of a physician group and say, well, what does that look like? How can we, if it's not someone from the outside pushing the string, living inside the group, how can we still create affordability? What are my levers for working inside a physician group? Policy, regulatory, payer. It's really inside a physician organization that I'll be addressing this. Although there's multiple other levers, and I think many people in the room can be addressing all of these, and we probably need to do all of them. So just looking inside a physician group, what are the components driving up the cost? Well, the number of visits is a big one, although that's not where the biggest dollars are, but that's something very much within our control. Then who do we refer from specialty to primary, from primary to specialty care? Now it starts getting more expensive, but now we start doing imaging and lab tests, and that's probably where a lot of that 30% is going to live, right? Then our treatment choices, what drugs do we use, what interventions do we do, and probably the biggest choice of all is the decision to operate or not. And while as a patient I would like to think that that's a black and white decision, either I need it or I don't, many of us know that that's not such a black and white decision. There's a lot of physician discretion there in who goes to the OR, who doesn't. So the question is, can we measure these patterns? And the answer is yes, it's all fee for service. We have down to the minute detail, the day, the hour, and the exact CPT code for every one of these things, so we have it. So the real question is, can we manage it? And we haven't so far, and in a fee-for-service system, the incentive is just do more and you'll get paid more, so that's one way of managing it. But can we change that around fast enough to live inside the new payment mechanisms? So when it comes to management, in job interviews I've often got this question, what's your philosophy of management? It's kind of a weird question, but I know what they mean by that, because if I'm dealing with physicians and I think you're ordering too many tests, what's my philosophy of dealing with you? So the most obvious is, I need to beat you with a stick and pull you along because you're not listening to what obviously is the right care. And that didn't work so well, and it wasn't received too well. So along came pay for performance. I figured, now we're going to do it much more friendly. So now I'm going to add carrots to this system, and now you're going to respect it because now I'm giving you rewards for doing the right thing. But it's still what I think is a bit of a backwards philosophy about how to manage physicians. Because just for a moment, imagine that physicians are this wild, strong, fierce, independent, proud, very powerful, wild stallion here, that with just a little bit of guidance about, look, this is what we're looking for. Here's a picture from The Horse Whisperer. And what if we can direct all that force into this harnessed force? And see, the last picture is not that different from the first one. Physicians want to do the right thing. So is there a way that just with a little bit of guidance we can point them in the right direction? So the contributors to overutilization, if my model is still in the carrot and stick method, I'm thinking, well, fee-for-service is the problem, and they're really self-interested. They just want to do what they're doing themselves. But if I'm more in the horse whisperer tradition, then I think, well, they just need a little bit more training, and maybe they haven't gotten any feedback. So how does that direct the solutions that I might be approaching here? If I'm just stuck in the fee-for-service or pay-for-performance is the only way to approach things, I'm going to be talking about aligning incentives, paying them, profiling them, talk about accountability, counsel the outliers, but it's still very much of a control mechanism. We've all lived under prior authorization. That didn't work so well, but it's still a punishment and reward system. And it doesn't feel good, as a parent, it works a little bit, but it doesn't feel good. It's not the right relationship. I don't think it's going to get us to that Shangri-La where we all want to end up. So if we try for a more respectful interaction, I might want to just give very respectful feedback, give them helpful, actionable information, helpful tools, decision support, trustworthy data, and a supportive learning environment. Yeah, sounds great, but how do you do that? Well, the first problem is, what if we don't do it? What have been the results of our traditional way of trying to get the overutilization out doing what we're doing here? It's burnout, both burnout from the physician leaders trying to get behavior change, certainly burnout from the people at the receiving end of the change, a lot of frustration, a lot of resentment too. The picture of changing physician behavior is not that good. We've talked about pay for performance as the hot new thing. I don't think it has moved the needle that much on utilization. Yes, on the quality scores, but we haven't bent the curve a whole lot there. engagement and increased professional pride and empowerment are possible with a new thing. And this sounds very California maybe, it sounds very dreamlike, but I want to show you what this looks like. So the tools in the old system are mainly compliance with evidence-based medicine, right? We know what the right thing to do is, so just do it. I'll punish you or reward you for doing it. In the new way, we talk about variation reduction. So what is variation reduction? It's where we bring small groups of physician peers together. And every word here is important. It has to be small, they have to be physicians, and they have to be peers. Because it has to be a setting where they know and trust each other, and they can create this safe environment. It has to feel confidential. It's not something that a health plan is doing to them. It's not something that's going to get public. And they all have to be there because they're there because they want to change. If they say, well, we're just a new group, we don't really trust each other, okay, you're not ready for this yet. And then pull, not push, is a very important thing because too often we said, I know what the desired improvement is, I know what the evidence is, so here's what you need to do. So this new approach is very different. We're just saying, like, I have a feedback tool for data, and what would you like to do? Where do you want to become a better physician? The way we do is we show the variation in care. And we all know that there's huge variation, but we all think we're normal ourselves until you're confronted with the evidence of what that looks like. So our unit of analysis is the episode. So we've licensed software that is what's called episode grouping. So for a single patient around a diagnosis, it looks at all the ancillary tests, imaging, medications, creates an episode. Now here's the key thing. We're going to make it visual and live and drillable. And then we're going to say, what are you curious about? What do you want to look at? In the hope that that exercise will then lead us to a project. In the old way of dealing with physicians, we had the problem, we did the analysis, we figured out what to do, then we had our action plan, and then we implemented it, and then we went to the clinician and said, here's what I want you to do, and if you don't do it, I'm going to have this compliance loop getting you to do it. The new way is we start with the clinicians. We say, we assume you want to do the right thing. We trust that you know. You're going to be better at interpreting this data than any analyst or any physician executive anywhere. So you decide what's right. So they do the analysis themselves, just like we were just doing here with the live data. Then they say, this is how we want to change, and they implement it themselves. So it's physician-led, physician-driven, and this works. So it works for small groups of peers. I said, why? The data has to be visual. It has to be live, so that we can just follow our curiosity here. And then the hardest part is not having these data tools. The hardest part is leading the conversation, because it's easy for it to go south. People get defensive and angry. So expert facilitation is really the key here. So does this work? Our intermediate success metrics are that physicians affect this feedback. It doesn't feel wrong or immoral or scary to talk about resource utilization. They accept the data validity, and they accept also this grouper methodology. Does it work in terms of saving money? Here's some of our projects. You can see how many months they've been running. This comes from Palo Alto Medical Foundation, where they've had a couple of years head start on this. So they've saved over $7 million just specialty by specialty, saying, pick something that you care about that you want to change. So it starts to add up.